We rarely consider the pressure inside the lungs. While the systemic circuit is high pressure, the pulmonary circuit is designed for low resistance. When this vascular resistance spikes, the right side of the heart is forced to pump against a stiff, high-pressure circuit. This gauge shows the hemodynamic threshold for pulmonary arterial hypertension. While normal resting mean pulmonary artery pressure is significantly lower, a clinical diagnosis is made when that pressure reaches or exceeds 20 millimeters of mercury. Clinicians diagnose PAH only when this pressure elevation occurs in isolation. It requires the absence of secondary chronic lung diseases, such as COPD. The disease follows a specific demographic pattern. It is most common in females, typically presenting between the ages of 30 and 50. Genetic factors are present in 1/10 of all cases, where the condition is inherited in an autosomal dominant fashion. Specific external factors also modify patient susceptibility, including HIV infection and the use of cocaine. Historical pharmacological data reveals further risks. Appetite suppressants, or anorexigens, have a verified link to the disease, specifically fenfluramine, found in the Pondamin bottle shown here. Diagnosing PAH identifies a primary vascular pathology. It initiates a mechanical failure that moves backward from the pulmonary vessels into the heart. This cross-section shows the microscopic trigger. The peptide endothelin drives intense vasoconstriction, while causing the surrounding smooth muscle to physically thicken and remodel. This fixed vascular resistance limits output during physical demand. Patients experience progressive exertional dyspnea, syncope, and chest pain. On a macroscopic level, high pulmonary pressure forces the right ventricle to adapt. This 3D model shows the ventricular wall thickening, hypertrophy, struggling against resistance. As it dilates, it creates a palpable physical sign. A clinician can feel this enlarged muscle pushing outward, a right ventricular heave. This back pressure slams the pulmonary valve shut early in the disease, producing a loud P2 heart sound. When the right ventricle eventually fails and output drops, the valve closes sluggishly, transitioning to a soft S2. These acoustic and tactile signs provide direct evidence of the right ventricle losing its mechanical battle against pulmonary resistance. The mechanical failure continues retrograde, moving past the ventricle to the tricuspid valve. As the right ventricle dilates, it pulls the tricuspid valve apart. Blood leaks backward into the right atrium, tricuspid regurgitation. The atrium now meets significant resistance as it attempts to empty its volume. This resistance is visible during a neck exam. Elevated right atrial pressure transmits to the jugular veins, resulting in a raised jugular venous pressure with prominent A waves. This systemic venous pooling eventually leads to visible cyanosis and peripheral edema. By examining the jugular venous pulses and the precordium, a clinician can map the progression of retrograde heart failure without specialized imaging. Management begins by addressing underlying conditions with oxygen or anticoagulants. Following this, the treatment strategy is determined by a specific hemodynamic test. This flowchart illustrates acute vasodilator testing. Clinicians administer rapid-acting vasodilators like intravenous epoprostenol or inhaled nitric oxide, checking if pulmonary arterial pressure falls. The results split patients into 2 pathways. Only a minority show a positive response. For these positive responders, the indicated treatment is oral calcium channel blockers. The results of this test define the patient's long-term management, separating those who can be treated with simple pills from the majority who require complex intervention. The vast majority of patients show a negative response to vasodilator testing, requiring targeted therapies. This cellular model shows the 3 pathways targeted in non-responders: prostacyclin, endothelin, and phosphodiesterase. The first strategy involves supplementing vasodilators. Prostacyclin analogs like treprostinil and iloprost bind to these receptors to induce vessel relaxation. The second strategy uses endothelin receptor antagonists. Agents like bosentan or ambrisentan cap these receptors, directly blocking the signals to prevent further narrowing of the vessel. The third strategy enhances vasodilatory pathways using phosphodiesterase inhibitors. Sildenafil, shown on this label, is utilized to inhibit the PDE pathway and reduce pulmonary pressure. Managing non-responders requires the simultaneous manipulation of these microscopic biochemical pathways to maintain blood flow. PAH is a pulmonary vascular pathology that systematically leads to the failure of the right side of the heart. The failure of the endothelial lining creates a retrograde pressure wave. This wave results in the physical signs detectable at the bedside, from altered heart sounds to jugular venous pulses. Even with targeted therapies, the disease often progresses. Here, a dilated right heart struggles to pump against the sustained resistance of the pulmonary vessels. For patients with progressive refractory symptoms, the definitive intervention is a dual heart-lung transplant. While pharmacology can manage the retrograde cascade for a time, long-term survival in advanced cases requires replacing both the vascular bed and the heart muscle.